Dr. Fox, thank you so much for joining us today.
You're welcome.
You know, there are several different molecular diagnostic tests that predict the risk of recurrence in early stage breast cancer. There's Oncotype DX, MammaPrint, Prosigna, that can all help predict breast cancer recurrence rates in early stage patients. So do you see any advantage of a decentralized test compared to a centralized laboratory developed test, or an LDT?
So I think the fundamental question is, what patient advantages accrue from having a decentralized test versus a centralized test? Certainly there are more rapid turnaround times with a decentralized test, but ultimately does that affect patient outcome? Patients aren't treated immediately, so I would say that at the outset there's probably no fundamental patient advantage nor payer advantage to having a decentralized test.
Maybe. I would think, psychologically, if I'm a patient with a cancer diagnosis, the sooner I found out the information that I wanted, the better. I mean, you're going to have sleepless nights waiting for this information if the turnaround's too long. It's got to be terrible, no?
Well, the question is, do I need chemotherapy or do I not need chemotherapy? I know I'm going to get hormonal therapy. Certainly there are psychological advantages to a lot of things. The question is, does that increase the value of the test, reduce the value of the test? Frankly, I'm indifferent as a payer to what test I pay for if the costs are the same.
Would there be a cost advantage maybe with the test?
From my vantage point, I don't really care where the test is done or how it's done. I'm simply paying for a prognostic test. So the fact that it's done in a laboratory setting or a centralized laboratory versus a decentralized one, I'd say no.
All right, well, in light of the recent FDA announcement on establishing guidelines for companion diagnostics and more rigorous evaluation of LDTs, do you foresee any changes in how you evaluate the new diagnostic tests and how you foresee future guidance impacting reimbursement decisions?
Well, certainly if there's a new standard that all LDTs need FDA approval, that creates a new floor for everyone and creates a level playing field. For example, the Abbott developed test to screen for ALK mutations in patients who had non-small cell lung cancer. Abbott developed that test, cost $1,500, and nobody uses that test anymore because the lab developed tests are significantly cheaper. And in fact, when the physicians order the test from their hospital lab, they don't know where they're getting the test from. So I would say that FDA approval creates a new floor for everybody that assures that there is similar clinical and analytic validity. In
your view, though, or not even though, but in your view, is FDA approval legitimate? Is it a good idea in this sphere?
Well, it certainly I think it's a good idea, yes, because it creates a public scrutiny, or at least FDA scrutiny, around the clinical and analytic validity of the test. Today we don't know what we're getting. We have to rely on the accuracy and the transparency of the information provided by the manufacturer of the test.
But at some point the test's got to measure up. I mean, if at some point the clinical world figured out that test A didn't work as well as test B, whatever the cost, they're going to migrate to test B.
Well, but the reality is, though, how many patients have both tests done? We don't, yeah. And if my hospital only stocks one or provides one of those services, then we really don't have the ability to do that comparative analysis. So it really has to be done at a much broader level.
So in your view, then, the value of the FDA as an honest broker can have a look at all of them across the waterfront and say, this works, this doesn't, or they all meet at least this standard.
That's correct.
So that's fair.
Yeah.
Good idea, then.
Very much so.
In your view.